Good afternoon, everyone. Welcome to today's Lunch and Learn. Dr. Elizabeth Stewart will be our speaker today. Take it away, Dr. Stewart.
Thank you. All right. For those that don't know me, I'm Elizabeth Stewart. I am fairly new here. I just started working at what used to be Jefferson, and I guess now is Tanglewood Pediatrics about a year ago now. And today I'm going to be talking about a quick overview of the 2021 guidelines for the management of well-appearing febrile infants. This is a 40-page document, so I'm obviously not going to be able to talk about everything, but hopefully I can hit the high points. Let's see. All right, so objectives. After this presentation, you should be able to describe the way that common pathogens and testing have changed over the past several decades and why our approach to febrile infants has changed. You should be able to stratify the risk of severe illness based on the age of an infant and describe differences in recommended evaluation, and to discuss the initial management and treatment for each of these patients. So quick overview of the guidelines. They were published in August 2021, so pretty recently. They developed 21 action statements after extensive literature review, and there were a lot of different people involved, including epidemiologists, pediatricians, and family doctors. The guidelines apply to well-appearing febrile infants. So these are babies that otherwise seem to be doing okay, but do have a documented fever either at home or in a clinic greater than 38 degrees Celsius, who are between 8 and 60 days. They have to have been term babies. So this only applies to babies with gestational age greater than 37 weeks, and they have to have been discharged from the nursery. So these are babies that have gone home and now have a documented fever. The committee acknowledges that there's still variability in how these may be interpreted or the risk tolerance of different clinicians or families. And so just because the guideline is there does not mean that you have to strictly follow it for each situation. All right, so how we got here. In the 1970s, the risk of GBS was starting to be more recognized, especially in babies that otherwise looked pretty good, but they just had fevers. And so at that point, there was pretty extensive workup. Lots of babies got LPs and labs, hospitalization, and antibiotic use for febrile neonates. Throughout the 80s and 90s, there were attempts that were made to develop some guidelines for the management of these babies, but there was so much variability in what people were doing as far as their workup and their treatment that it was hard to generalize and to make strong recommendations because the studies were all so different. Most of those guidelines relied on the age of the baby, the appearance of the baby, UAs, ANC, and CSF. Those guidelines generally had pretty high negative predictive value, but low positive predictive value. So lots of babies got lots of labs and treatment, but most of them did not ultimately have severe infections. And so the goal of these guidelines was to develop low and high risk babies and give a general recommendation, but there was still a lot of variability in what different providers were doing. And so the goal of these 2021 guidelines was to make things a little bit more uniform. So a little bit how bacteriology has changed over the last 40 years. So there's been a shift from gram-positive to gram-negative organisms. Some of the reasons for this, because of improved prenatal GBS screening and treatment, strep pneumo immunization, as well as better food safety. So Listeria is not seen very much anymore. E. coli is now the most common cause of bacteremia. It's about 90% of UTIs in this population, 30 to 60% bacteremia, and 15 to 30% of bacterial meningitis. So this does change what tests and treatments are most appropriate. So if we're thinking about a gram-negative organism instead of gram-positive, then the white count and the ANC are going to be less helpful, and things like the CRP and ProCal are more accurate. So why did they focus so much on age in these guidelines? So previous guidelines generally considered any baby under 28 days to be high risk, and then babies from 28 to 60 days were in a different category. But more recent studies have shown that in the fourth week of life, there are significantly lower rates of infection than in the second and third week. So the guidelines actually separate their recommendations into the categories of 8 to 21 days, 21 to 28 days, and then greater than 28 days. Because if you look at these graphs, these are some pretty large multi-center studies that have been done. And all of them show that the infection rate is absolutely highest in the 8 to 21 day range, but then drops off pretty significantly by the time you get to 22 days, and then it's even lower by the time you get to 29 days. So these were the groupings that they chose to use for their guidelines. If you look at this PCARN study, that was in almost 5,000 infants across multi-institutions, and that showed that the rate of bacteremia in the 4th week was only 1.6, compared to 5.3 in week 2 and 3.3 in week 3. And there's really no difference between week 4 to week 6. And so, having these babies in the higher risk category didn't make as much sense as considering them separately. So quick overview of who these infants or who these guidelines did not apply to. So like I said before, it's preemies, so the baby has to be greater than 37 weeks to use these guidelines. It doesn't apply to infants less than 2 weeks with a known maternal infection or fever. Infants that are high risk for HSV, so if they have vesicles or a mom that was positive. If there is a known other focal infection, so if they have a cellulitis or an umphalitis, osteomyelitis, they don't fall into these guidelines. Interestingly, infants with bronchiolitis do not apply to these. So if they have bronchiolitis and they have a fever, then they should be considered separately. But it did mention that there were multiple studies that showed that if a baby has documented bronchiolitis, then there were basically no rate of bacteremia or meningitis in those babies. So it seems to be pretty low risk, but need to be considered separately. If there's a baby that has a known or suspected immune compromise, obviously you need to treat them a little bit differently. Same for babies with chromosomal or congenital abnormalities or medically fragile infants, or for infants who have received immunizations in the last 48 hours. So these babies you may expect to have a little bit of a fever. And so, if you otherwise, baby looks well, they just had an immunization, then they may not fall into these categories. Babies that can be used or can be used under these guidelines are babies that have mild respiratory symptoms, babies who have diarrhea, babies who have been diagnosed with otitis media and have been on antibiotics recently, or babies who have positive rapid viral tests. There was a lot of discussion about the use of viral testing in this paper. And if you're interested in that, you may want to read the whole thing. But because the viral testing is so new, nobody really knows what exactly we're supposed to do with it and how it changes the management of febrile infants. And so generally the recommendation is even if they have a positive viral test, you should still follow these guidelines to make sure that there's nothing else serious going on. Okay, so just a quick reminder of how the AAP looks at evidence. So they aggregate their evidence quality from A to D. So level A evidence would be meta-analysis or well-designed randomized controlled trials, things like that. And then it goes, weaker evidence would be the B, C, and D. And then they take that evidence quality and they consider the benefits and the risk, and they decide whether something is a strong, a moderate, or a weak recommendation. Okay, so going into the guidelines a little bit, the first grouping that we think about is the infants who are 8 to 21 days. And this is probably going to look pretty familiar. The workup is basically the same as what we've always done or what I was familiar with during my training. So for these babies, you are going to get a UA via a cath or a SPA. If it's positive, you send it for a culture. You're going to get a blood culture. You can get inflammatory markers, though they're maybe not going to change your management very much. And then you're going to obtain CSF. So these babies still need to be tapped. You may consider getting HSV if there's CSF pleocytosis or if there are other risk factors. Treatment for these babies, you're going to start antibiotics. You're going to admit them to the hospital, ideally in a place with experienced pediatric neonatal nurses who are used to working with infants. And then discontinue antibiotics after observing cultures for 24 to 36 hours. The length of treatment may be a little bit different. I think we've kind of slowly crept shorter and shorter on how long we have watched the cultures in these babies. But some of the reasons that we're able to do that now is because of our automated blood culture technology and some of the PCR detection tools. And so if a baby is going to have a positive blood culture, for the most part, it's going to be within the 24 to 36 hours. So they felt like it was appropriate. The baby's still well appearing. And if their culture is negative at 24 to 36 hours, then you can send them home. And then obviously if their blood culture, their CSF, or their urine culture is positive, then they're treated appropriately. And then there are these flow sheets for each of the patient populations, which are really helpful. And so if you just need a quick reference of what to do with one of these babies, there's a flow sheet for each. So this is basically what I just talked about. Okay, so moving on to the workup for infants 22 to 28 days. I think this is the one that's the most confusing because there's some variability in depending on what you want to do. And then the treatment is a little bit different because these babies are kind of in the middle as far as their level of risk of serious infection. So the beginning steps are the same. So you're going to obtain a UA. They do say that you can get it via cath, or you can do a bag or a stimulated void. And if the UA is normal, then you can say you're done. The UA is abnormal, then you need to cath the baby and send that for a culture. So potentially it could save you from cathing some babies if their UA was normal from a bag. You also are still going to obtain a blood culture, and then you're going to get inflammatory markers. The inflammatory markers that they recommend are a CBC with a diff, so you want to get that ANC. You want a CRP, and then ideally a procalcitonin if it's something you have access to. Although they said if you're in a place that you cannot get a procalcitonin from your lab, then that's okay. You can just use the white count and the CRP. They also consider an elevated temperature to be a marker of elevated temperature more than 38.5 to be a marker of inflammation. And so if the baby has a temp at any point that's higher than 38.5, then you consider that to be a positive or an abnormal inflammatory marker. And then the other cutoffs are an ANC of either 4,000 or 5,200, depending on which study you use. It seems like they weren't willing to commit to one of those numbers, so they just put them both in there. So depending on which one you're more comfortable with, somewhere in the 4,000 to 5,200 range. A CRP greater than 20 or a procal greater than 0.5. You can obtain CSF regardless of the above tests, but you don't necessarily have to. And then you should obtain CSF if any of your inflammatory markers are normal. So they recommend kind of a step-by-step approach. You get your UA, your blood culture, and your inflammatory markers. If your inflammatory markers are high, then you definitely need a CSF. And then treatment for these babies. If your UA is positive, or if there's any concern for bacterial meningitis, then you're going to treat with IV inpatient antibiotics. You can administer antibiotics if the UA is normal, the CSF is normal, and any inflammatory marker is abnormal while you're watching your cultures. Or if you're more comfortable and the family is more comfortable, you can administer antibiotics even if your whole workup is negative. There is a very low risk that still exists for bacteremia or meningitis. So this is a conversation you have to have with the family about what their level of risk tolerance is, what your level of risk tolerance is, and what you feel like the access to resources is. So the other option that is available for these babies is at-home management. So if a 22 to 28 day old has a normal UA, normal inflammatory markers, normal CSF, then you can send them home if you give verbal teaching and written instructions for what the family needs to look out for, what the return precautions are, and a follow-up plan within 24 hours. They do recommend sending these babies home on oral and on parental antibiotics. So you give a dose of ceftriaxone, you send them home, you see them back within 24 hours to check back in. The risk of bacteremia is still 1 to 2%. So you have to be sure that this is a reliable family that's going to come back in. And if the culture pops positive, that they're going to be able to bring that baby back into the emergency room. If you're not able to get CSF, or if you choose not to get CSF, then they do recommend that the baby be managed in the hospital. Okay. And then same thing, you discontinue your antibiotics after 24 to 36 hours if the baby's still well appearing, the cultures are negative, and then you treat appropriately if any of your cultures are positive. So I'll talk through this one more time because I know it's a little confusing. So basically for 22 to 28 day olds, you get your UA, your blood culture, and your inflammatory markers. If your UA is positive, then you definitely have to get a cath. If your inflammatory markers are abnormal, then you need CSF. If everything is normal, then you can perform an LP, but you don't necessarily have to. If you don't perform the LP, the baby needs to be admitted to the hospital on antibiotics. If you perform the LP and the CSF is normal, then you can send the baby home after a dose of IV antibiotics and follow up within 24 hours. Okay, and then the last thing I'm going to talk about is the workup for infants from 29 to 60 days. So same thing, you're going to obtain a UA. Again, you can get a bag or a spontaneous void if you don't want to cath them straight out. But if it's positive, you do need to confirm with a cath and send that one for culture. They found that the rate of leukocyte esterate negative positive cultures was similar to the rate of asymptomatic bacteriuria or contamination. So they felt like if your UA is negative, then you don't have to have a culture. They felt pretty strongly that was reliable for diagnosing babies with UTIs. You do still want to obtain a blood culture, and you want to assess the inflammatory markers. You can obtain CSF if any of the inflammatory markers are abnormal, but you don't have to. And if your inflammatory markers are all normal, they felt like you do not need CSF. I saw a comment from Dr. Locktier that was asking about GBS positivity. There is in their exclusion criteria, they said maternal infections excludes babies from being included in these guidelines if the baby is within 2 weeks old. So I think you would have to kind of weigh the risk and benefit of if it was a fairly young baby with inadequately treated GBS, you probably couldn't use these guidelines. Okay. And then treatment for infants from 29 to 60 days. You're going to use parenteral antibiotics if your workup suggests bacterial meningitis, obviously. You can use your parenteral antibiotics if your CSF is normal, but you have abnormal inflammatory markers. You're going to use oral antibiotics if all you have is an abnormal UA and you have normal inflammatory markers. And you do not need antibiotics if your CSF is normal, your UA is negative, and your inflammatory markers are normal. The risk of well-appearing infants with all of these having negative findings for bacteremia is 0.1%. So there's still a small risk, but they felt like the risk of giving antibiotics to all of these babies outweighed the benefit of treating the one who may later develop other symptoms and then present back to care. Okay, and then for hospitalization for these babies, obviously if you have abnormal CSF, that baby is getting admitted. You may hospitalize any infant with an abnormal inflammatory marker, but you should manage at home if everything is normal. You do still need to make sure that you're providing appropriate parental education. You need a follow-up plan within 24 hours, and the family needs to be able to communicate with the inpatient team or with the emergency room team if the culture were to come back positive, and they need to have transportation to get back to the hospital. So I think, again, you have to weigh the risks and the benefits and each specific family to make sure that if something happened, they would be able to come back to the hospital. You can manage them off antibiotics if everything is negative, again, as long as they can come back promptly. And maybe that, oh yeah, that's what I just said. Okay. And then Dr. Locktier again said, what about late onset? That I'm less sure about. Again, I would think if it was inadequately treated, you might need to think about it a little bit more carefully. Adequately treated GBS, late onset or further out, maybe it would fall into these guidelines, but it didn't specifically talk about that. All right. So again, you're going to discontinue the antibiotics after 24 to 36 hours, and you're going to treat positive cultures. All right. And here is the flow sheet for these patients. So basically, well-appearing baby with a fever, UA, blood culture, inflammatory markers. If the inflammatory markers are high, then you can perform an LP. We don't necessarily have to. If the inflammatory markers are normal and you have a positive urine, then you're going to treat the baby for that. If everything is negative, then you're going to send them home off antibiotics. And if the baby gets admitted to the hospital, you're going to watch for 24 to 36 hours and then discontinue antibiotics after that if they're still negative. Okay, so in summary, changing pathogens and new technology allow us to manage these babies differently than we have in the past. There's significant variation in risk based on age, so the approach is different based on how old the baby is. Obviously, the younger the baby, the higher the risk. And you can use the algorithms for a stepwise approach. I think if we have the ability to get a CRP back quickly within our outpatient clinic, this may be something that we're able to do if we have families that we feel like are reliable enough to follow up closely. Because some of these babies do not need LPs and do not need admission to the hospital. So these may be some more babies that we could manage within the outpatient clinic than we were previously doing. But obviously these guidelines provide a framework, but do not apply to all patients and families. So some families may be more or less risk averse. There may be differences in the geographical or social situations. There are charts in the paper to discuss risk and benefits with families regarding, do we do an LP or do we not? And they can be really helpful. So this chart is talking about CSF. I think this is for the 24 to 28 day babies. And so, if you're having this conversation with the family about, do we do CSF versus admit or things like that, then it gives you different benefits and risks, and then how the patient preferences may come in. So these are a nice way to be able to have those conversations with families.